my presentation focused on two areas of vision rehabilitation and really one major kind of overarching point, which is that this is an invisible disability area and is undertreated and underappreciated. So I and my colleagues really emphasize that, these problems can be diagnosed accurately. And then in the area of both visual field cuts and visual spatial disorders, I presented some of the information on practical means of treatment. So we talked a little bit about some of the means for visual field cuts. They're really kind of compensatory approaches that have been recommended in guideline documents. And then most of my presentation focused on the rehabilitation of visual spatial neglect, which is a disorder in which people don't orient or act appropriately in the side of space opposite a brain lesion, and they can be very severely disabled. In fact, it can be even more disabling than paralysis or speech and language disturbance because it disrupts just basic activities of daily living and independence. So I really focused, although there are a few different areas in which there has been evidence basis or tried and true treatment presented for visual spatial neglect, I focused on an approach which is very practical for inpatient rehabilitation and also for outpatient rehabilitation called prism adaptation therapy. And that's an approach that can be taught to a therapist in about a half a day. It involves wearing wedge prisms, and I apologize that I don't have the wedge prisms, but the prisms basically, form a wedge and shift what the person sees in the direction of the point of the wedge. So these are wedge prisms that point to the right after a right brain injury, in which this problem is more common. And they're just off-the-shelf prisms that are mounted in a goggle, and for about 20 minutes, the person wears the prisms and points to objects. The person does not have to learn kind of a philosophy or administer self interventions or, implement knowledge at other times. It's just a 20-minute session over a period of 10 days. And in general, what's recommended is to do those 10 days of treatment over 2 weeks, but sometimes we've done that over slightly longer periods. And probably about now 30 or so rehabilitation and outpatient sites in the U.S. are doing this treatment, although there have been in some studies, the results have varied. What I and my colleagues have proposed is that when people have a lot of motor symptoms, so when, for example, after a right brain stroke, they have difficulty orienting, but in particular kind of this turning or rotating tendency toward the side of their stroke, those people tend to respond much, much better. So in my presentation, I proposed, as my group and I have published, that it's very likely that that subgroup are the ones who are driving the positive effect. And so studies have, included different numbers of people of other subgroups, and that's muddied the waters a bit. It's a very feasible approach, and in particular, individuals who have this problem. Unfortunately, all of these visual problems are not only sometimes invisible to the people around the patient or the stroke survivor, but they're actually sometimes invisible to the stroke survivor themselves, whose alarm system is offline, and they don't realize that they have either a field cut or spatial neglect. And the great thing about this prism adaptation therapy is as long as they can sit up and make movements, they don't have to acknowledge that they have a problem. They just have to cooperate with the treatment because it acts at a very low level of kind of motor retraining. We hope in the research that we're doing now that is funded by the VA, what we're hoping is that we will have methods of looking at people's brain scans, which are always taken, of course, in the first hours after stroke. Right now, what we have advocated is that people might start with prism adaptation therapy and then evaluate further. So our this approach is not not specifically investigated. It's based on expert wisdom. But in this secondary approach, they have kind of a first line, a second line, and a third line approach. You might utilize other approaches that are shown to be beneficial, that have been shown to help patients to do their everyday activities in kind of randomized settings, controlled settings. So some of these involve movement of the left body, of the opposite side of the body, of the thoracic side of the body. Some of them involve scanning training, and visual scanning training has also been an approach that's been utilized for visual field cuts. And the problem with visual scanning training, it might be more appropriate for certain groups of people with spatial neglect, but it has not been shown to generalize well, for example, to other things that are not specifically trained. So oftentimes people are trained kind of to read, or they might be trained to scan, in a kind of a desk environment, but they're not really trained to scan in their refrigerator or in their kitchen, places where they and their family really prioritize them to have a good visual spatial ability. So we're still in the process of working on these aspects of the care of patients. A question that oftentimes arises is if people do respond, for example, to prism adaptation therapy or to some of these other therapies, would the response last? And unfortunately, again, with visual scanning training, there's different results. And in some patients, it doesn't seem the results last well or robust. That's another reason we favor you trying as a first line the prism adaptation therapy, because the studies that have been done that showed effect with prism adaptation therapy over 3 to 6 months showed persistent effect over that period. But unfortunately, there are not a lot of studies yet of people over years. That's particularly difficult, of course, because it's a very fast-growing segment of people with stroke between the ages of 30 and 45. So we would really like to know what responses people have over periods of 10, 15 years and longer.